we'll go ahead and get started since it's 3:01. My name is Heather Holland, and I'm the Director of Education with the Cancer Support Community. Welcome to our webinar, Frankly Speaking About Cancer, What is New with Immunotherapy, hosted by the Cancer Support Community. If you need technical assistance during the webinar, please dial the following number, 1-866-229-3239, and choose option number 1. So before we start, I'll go over some reminders and housekeeping items. If you would like to listen to today's presentation via telephone, please dial in using the conference line code you see on the screen. Today's call is being recorded and will be available on our website at www.cancersupportcommunity.org/webinars within the next few days. The format of today's webinar will be as follows. The panelists will present first, and then we will open the discussion up to the audience during the question and answer session. Thank you to those who submitted questions prior to the webinar as part of the registration form. If you would like to ask additional questions, please feel free to type it into the Q&A box on the right of your screen. You may submit a question at any time during the event. At the end of this webinar, you will be automatically redirected to the post-webinar survey. Please take a few minutes to complete the survey as your input helps us improve our future webinars. Perfect. So I'd like to introduce the Cancer Support Community and talk a little bit about what we do. We are the largest professionally led nonprofit network of cancer support worldwide. CSC is dedicated to ensuring that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community. We offer the highest quality social and emotional support through our affiliate network as well as online or over the phone. So on this screen, you'll see some of the resources that we provide at the Cancer Support Community. The first one is the Cancer Support Helpline, which is staffed by licensed professional counselors who are available to assist you Monday through Friday, 9 a.m. through 9 p.m. Eastern Time. We also have our Open to Options program, which is a research-proven program that can help you prepare a list of questions to share with your doctor. We have our Frankly Speaking About Cancer program, which is CSC's landmark education series that provides trusted information on a variety of topics that are important to people affected by cancer. Information is available through print and digital publications, online, and in-person programs. For the complete list of publications, please visit orders.cancersupportcommunity.org. So I'd also like to introduce our Cancer Experience Registry, which is a unique project for people affected by cancer. People who have been diagnosed with cancer and those who help care for them can join the registry. We welcome you to join. You begin by answering survey questions, and your answers and those of others describe the experience of cancer patients and caregivers. This information is incredibly important to us, and it's used to provide education and support resources that speak to patients, caregivers, and their needs. For more information or to join, please visit www.cancerexperienceregistry.org. So I'd also like to take a moment to talk about our grassroots movement, which helps ensure that people touched by cancer have access to quality, comprehensive cancer care that includes social and emotional support. Again, if you would like to learn more about this program or to sign up, visit our website at www.cancersupportcommunity.org/join-our-movement. So I'd now like to introduce our panelists, Dr. Waterhouse and Dr. Lyerly. Dr. David Waterhouse is the co-chair of the Clinical Research Program at Oncology Hematology Care Incorporated. At any given time, Oncology Hematology Care has 55 to 75 cancer clinical trials open or pending, many of which are for immunotherapy treatment. He received his medical degree from the University of Massachusetts Medical School and has been a practicing medical oncologist for more than 20 years. In 2017, Dr. Waterhouse was recognized by U.S. Oncology with their Excellence in Clinical Research Award. We also have Dr. H. Kim Lyerly. He serves as a professor in the Department of Surgery, an associate professor in the Department of Pathology, and assistant professor in the Department of Immunology at Duke University Medical Center. Dr. Lyerly serves as the George Barth Geller Professor for Research in Cancer and is an experienced surgical oncologist. He received his MD from the University of California, Los Angeles over 30 years ago. So thank you to both of our speakers today for joining us. So today's webinar will give an overview of immunotherapy and current FDA approvals for immunotherapy treatment. And Dr. Waterhouse is going to start off by talking about and explaining what immunotherapy is. So with that, I will hand it over to Dr. Waterhouse.
Well, thank you very much for that kind introduction. I suddenly am feeling old. So to those of you who are out there who are battling cancer, don't give up hope. Things are changing very rapidly. One of the greatest changes that I've seen in my career is really the reemergence of immunotherapy as a means of battling cancer. To those who are caregivers out there, thank you for the help. It does take a village. And to cancer support community, I'll thank you even early, because what you do daily for our patients really makes a difference, and what you do on a national scale, being patients' advocates, really is truly helpful. So what is immunotherapy? Well, if we think about how we battle cancer, we first think about surgery. Can you remove the cancer? Sometimes we'll think about radiation therapy and using electrons in order to fight the cancer. We're all too familiar with chemotherapy and the value and the hardship that chemotherapy does. But what about our own body? What about our own ability to fight cancer? Well, that's what we're talking about with immune therapy. It's the idea of allowing our body's natural resources to turn against the cancer, treat it as foreign, and attack it. And so when we talk about immunotherapy, we're talking about multiple ways of essentially bringing our own body's immune system in on the fight and helping it to do a better job to fight against the cancer. Because let's face it, when you develop cancer, it is a reflection of the fact that this cancer was able to evade or overcome our body's own immune resources. So we can think about the immune system and our treatments as boosting the immune system or revving it up, juicing that immune system to fight. We can think about immune therapy as trying to make those cancer cells more easily identified by the body as being foreign or something we don't want, and being able to fight it. Or we can talk about helping the immune system by creating an environment that the cancer has to live in that is friendly to the immune system and unfriendly to the cancer. And we'll get more specific about some of these different ways as we talk about some of these kinds of drugs. So one of the first questions that patients ask is, why me? What happened? Why did this cancer get a hold of me? And why didn't my own body's immune system fight back? Well, it may have. It may not have been able to fight enough. Sometimes the cancers are able to evade the immune system and keep the body's own immune system from being able to respond. Some of the ways that this do this is that the cancer cell, which emanated from normal healthy tissue, looks too much like the body's own normal tissue, and the immune system doesn't identify it as foreign or as evil. Sometimes the cancer can basically hijack the regulatory system that we have in our immune system and hide from our body's immune system. You know, our immune system is geared to be quiet when it needs to be quiet and to rev up when it needs to fight. And the regulatory system we call immune checkpoints. And cancer cells can hijack those immune checkpoints and basically permit that cancer cell or cells to hide from the immune system. And then some people just simply don't have a healthy enough immune system to be able to mount that attack back. And so all of our approaches to immunotherapy are basically looking at each of these different kinds of areas and trying to target them and to enhance our body's immune system to be able to fight back against the cancer. So is immune therapy right for the patient, or if it's one of your loved ones, is immune therapy right for them? Well, I'll tell you, the first thing you have to do is ask their doctor. While immune therapy is becoming far more widespread and rapidly being adopted, not just here in the United States, but worldwide, it is not for every cancer and not for every stage. Immunotherapy has, to a large extent, been advanced predominantly in more advanced cancers, stage 4 cancers. These are cancers that have often spread from one point of the body to another, metastatic disease. But we are seeing now emergence of earlier stage trials where the immune therapy is given prior to surgery, neoadjuvant. It's being given after surgery, even though the tumor's been removed, what's called adjuvant therapy. It's being given in combination with other treatments, whether it be chemotherapy, radiation, targeted therapy, or precision medicines. So the only way to learn this for any one person's specific cancer is to address this question with their doctor. Now, as we say immunotherapy, I think a lot of you largely think about the TV commercials that you're seeing when you're watching the shows tonight. There are many different types of immunotherapies, as I just mentioned before, and they reflect the fact that there are multiple ways that we can either turn on our immune system, enhance its ability to work, change the microenvironment for which these cells are going to work in. And so immunotherapy comes in many sizes and shapes. This is a listing of just some of those kinds of immunotherapies. We are already familiar with monoclonal antibodies. These will target a specific, often protein receptor on the surface of a cell. Monoclonal antibodies have been around for quite some time. You've heard of the drug rituximab being used in the treatment of lymphomas, Herceptin in the treatment of breast cancer, and many others. Immune checkpoint inhibitors, these are the ones that are getting an awful lot of press these days. These were probably the breakthrough immune therapies, and they've only been around for a short period of time, and we'll go into some of those specifics. We mentioned before that there are regulatory properties of our immune system to turn on and to turn off the immune system. The checkpoint inhibitors are basically attacking points in that regulatory system that allow us to keep the cancer cells from being able to evade the immune system, or by turning back on those immune cells that were inactivated by the cancer. Often these are T cells or killer cells. And some of the examples of these are the PD-1 and PD-L1 inhibitors, CTLA-4 drugs, and there's a whole host of others coming down the road. Even more recently has been the CAR T-cell therapy, and you'll hear a lot more about this later in this talk. CAR T-cells probably are, again, the next big transforming therapy that we're seeing. And I won't go into a lot of detail because you'll be hearing more about those later. We know about cancer vaccines. Provenge for the treatment of prostate cancer is currently the only FDA-approved vaccine, but there are a whole host of them in development right now. And then you talk about oncolytic viruses. These are genetically modified viruses that are being turned against cancer. And viruses are used as a means of introducing genes into the system. So, again, these are just some of the examples that are currently being done, and there are certainly more. In our preview phone call earlier today, we talked about the fact that there are probably over 1,500 clinical trials ongoing right now in the United States alone looking at different immunotherapy approaches to the battling of cancer. So we thought we'd take a few minutes to talk about some of the checkpoint inhibitors that you probably have already heard about. Ipilimumab, also known as Yervoy, the trade name, and many of the doctors will call it Ipi for short, was actually the first approved immune checkpoint inhibitor. And it received its approval from the FDA in March of 2011 for the second-line treatment of melanoma. So these were patients who had already failed a previous treatment. Now, that indication has been expanded over the years. And again, I'll talk about those a little bit more in detail. We've got the PD-1 and PD-L1 inhibitors. While Yervoy was perhaps the first of the immune checkpoint inhibitors, it was really the introduction of these PD-1 and PD-L1 inhibitors that were the game changers. And these drugs often are given alone, but can be done in combination with other therapies. Now, one of the attractions of the immune therapies, and maybe even the greatest attraction, is that oftentimes they're being found as effective, if not more effective, than chemotherapy, with significantly less side effects. That doesn't mean that there are no side effects. The side effects generally fall into two very broad categories. There are inflammatory side effects, and then there are also side effects that result in deficiencies, often of hormones. When we talk about side effects, your doctors will actually grade side effects. They will grade them as 1, 2, 3, or 4. Grade 1 and 2 side effects are the kind of side effects that are tremendously bothersome to the patient and troubling to them, but not necessarily barriers to treatment. I would use, for example, nausea. Grade 1 nausea is simply you felt a little bit sick to your stomach, but you didn't even reach for medicine. Whereas in grade 2, you might have felt a little bit nauseated, but you took your antiemetic medicine and it went away. It is a bother, it's troublesome, but it's not going to keep you from getting your treatment. But when you get to grade 3 and grade 4, when not only are you nauseated and vomiting, but you are getting terribly sick, you're becoming dehydrated, you need IV fluids, you may even end up in the hospital. When you get that sick, that becomes a barrier to treatment. And so grade 3 and grade 4 side effects are the more serious barrier-type side effects. So if we look at immunotherapy, the common side effects usually are simply grade 1 and 2. Grade 3 and 4 side effects are often in the single digits and not terribly common, but patients can get fatigue. That's probably the number one side effect that we see. Every once in a while we'll see a very small diminutive rash. Often that can be treated with steroids and taken care of. Same thing with muscle pain, flu-like symptoms. The more serious side effects and the ones that can be barriers if they're not addressed early are the inflammatory side effects, colitis. Again, not seen commonly, but when it happens, you need to be able to address it very quickly, very early, and your doctor should be made aware of it. Often manifests itself as stomach pain or diarrhea. Thyroid problems, usually a low thyroid, can be identified. This is very common with the immune checkpoint inhibitors, or among the more common, I shouldn't say very common, but more common side effects, and we often will routinely be testing thyroid levels. Lung problems, what we call pneumonitis, an inflammatory process within the lungs. For those people with lung cancer who are being treated, this can often mimic some of the presenting symptoms of lung cancer. So again, your doctor should be very familiar with these side effects. Other less common autoimmune conditions, such as pituitary deficiency or diabetes, can occur. But as I said before, these side effects most often have to be addressed because they are trouble, but usually are not a barrier to treatment. And often these side effects are significantly less than what we see with conventional chemotherapy. The severe side effects that we started to allude to would be troubling diarrhea, shortness of breath, abdominal pain, headaches that just will not let up, neuropathy, hot and cold sensitivity, lightheadedness, dizziness, The truth is, we could go on forever with these kind of lists. My encouragement as a provider and a medical oncologist, if you are troubled and wondering if you should call the doctor, you already answered your own question. Yes, please call. It's important that we have the opportunity to step in and step in early. And don't be afraid to ask questions, and don't be afraid to bring these symptoms to the attention of your providers. More often than not, we can do something about it and usually can reverse these problems. So the next slide, again, just reiterating what I just said, please make that call. And call us first. I know in my own personal practice, we would much rather get your phone call than to find out you waited until you were really sick and ended up in the emergency room. Go ahead and call us. We'll answer the phone and we'll talk to you about it. The next several slides now are talking about some of the specific agents themselves. I mentioned ipilimumab or IPI earlier on, and this was, again, the first of the immune checkpoint inhibitors to get its drug approval. These drugs are young. The first indication came in March 2011, as I said, in second-line melanoma. The use of this drug now has been moved up into the frontline treatment. It's even approved in pediatrics for adolescents and children, 12 years and older. So the immune checkpoints are not simply for adults anymore. A lot of progress being made on this drug. This is a drug that is also being explored in other cancers, most notably in lung cancer, but you're going to hear about it in other cancers as well. Nivolumab, or also known as Opdivo. Although ipilimumab was the first of the drugs to be approved, it was approved in a disease that is not terribly common, malignant melanoma. And I would argue that nivolumab and pembrolizumab, these are both known as PD-1 inhibitors, were really the breakthrough drugs. These received their FDA approval in March of 2015, was the first approval, and it was in second-line non-small cell lung cancer, where for the very first time we saw the survival curve of this incredibly dreadful disease bent. We saw survivors, long-term survivors, and some of the patients in those original trials are still alive today, free of their cancer. While the drug was first approved in the treatment of non-small cell lung cancer, you can see that the FDA has expanded the indications to multiple other cancers already. In bladder cancer and in colorectal cancer with patients who have what's called microsatellite instability. We're seeing it used in head and neck cancer and in hepatocellular, also known as liver cancer, in Hodgkin's disease or in classical Hodgkin's lymphoma, also in melanoma, often combined with ipilimumab, but also as a single agent, in kidney cancer, and again, probably most commonly used in non-small cell lung cancer, simply because it's a much more common disease. And in lung cancer, its approvals are in the second line of therapy for nivolumab, those patients who had already received chemotherapy or a targeted agent. But there are clinical trials ongoing in the front line. Along with nivolumab, we have to talk about some of the other immune checkpoint inhibitors. Atezolizumab, also called Atezi by many of the oncologists, was actually the third immune checkpoint inhibitor. This one is what they call a PD-L1 inhibitor. And much like nivolumab, approved in second-line lung cancer, and was the first of the immune checkpoint inhibitors to be approved in the treatment of bladder cancer. Prior to this drug, patients who had failed chemotherapy with bladder cancer did not have a lot of good options. Pembrolizumab, I already mentioned. This one, the approval for this drug came right at the heels of nivolumab, and it is also a PD-1 inhibitor. This drug has many of the indications, similar indications to nivolumab, but there's a little bit of difference. For example, this drug can be used in gastric cancer and cancer of what's called the GE junction, where the esophagus meets the stomach. It's also used in Hodgkin's disease, in head and neck cancer, also a treatment for melanoma, one of our options, used predominantly in non-small cell lung cancer, and actually has the first FDA approval for first line in those patients who have what's called a high PD-L1 expression. So this is a marker on the surface of the cancer cells that can be measured, and when the PD-L1 level is high, greater than 50% of the cells expressing this marker, this can be a treatment option where patients in the first line treatment or the initial treatment of lung cancer could receive an immunotherapy without chemotherapy. So that was, again, considered a breakthrough indication. Also being used in bladder cancer, and it has an indication that is perhaps, in my personal opinion, one of the most important breakthrough observations in all of our treatments. Most drugs get their FDA approval based on a specific cancer and anatomic site. So a drug is approved for the treatment of breast cancer. A drug is approved for the treatment of lung cancer, gastric cancer, and the like. But what if instead you didn't care where the cancer came from, but rather just about some of the characteristics of the cancer? Well, this drug got the first FDA approval for the treatment of any cancer, so long as it tested high for what's called microsatellite instability. And so this drug was basically agnostic of the tissue type. It didn't care what kind of cancer it was. It cared about the receptors or the proteins on the surface of that cell, and it doesn't differentiate whether it is a lung cancer, a breast cancer, a colon cancer. And so this is an important breakthrough, and I think we'll see more of this kind of work going forward. Moving on, avelumab. If you're getting confused by the names of all of these drugs, well, you can join your doctors in that. There are many nibs and nabs that we have to know now. Avelumab got its first indication for the treatment of Merkel cell tumors. These are actually rather rare cancers that begin just below the skin in neuroendocrine tissue. It's often, even though it's approved for children 12 years and older, this is really a disease that we see more in older individuals and individuals with weakened immune systems. This drug also has been approved for the treatment of bladder cancer. So you can see that while this whole thing began, the modern era began with ipilimumab, you can see that there are now a host of drugs that are currently out there and being used, and there are many, many more in the wings, both as single agents and as combination agents. Durvalumab is yet another one. This is a drug that's been approved for the treatment of bladder cancer. Some of you may be asking, I noticed that there's a lot of lung. I know there's a lot of bladder cancer. I'm hearing about some special types of colon, but there's some others that I haven't heard about. Many of these initial treatments are because these tumor cells and these tumor types tend to express the target receptors for these drugs more than other cancers. But don't despair if this is not if none of these are the cancers that you or your loved ones are battling. These drugs are being tested pretty much in everything. It may not have reached the point of commercial success yet, but you can bet they're being tested in many different lines of treatment. So this was meant to be an introduction to many of the drugs that currently have FDA indications and therefore are available to you. But again, there are many more in development. So be aware of that, and as you think about treatment, begin to think about clinical trials as being a viable, if not sometimes a preferable option of treatment. And at this point, I'm going to turn it over to my colleague, who is, Dr. Lyerly, is going to be talking about what is, again, another major breakthrough in immunotherapy, the CAR T cells.
Awesome. Thank you, Dr. Waterhouse. And at this time, Dr. Lyerly will talk to us about CAR T-cell immunotherapy and some other newer immunotherapy options. So I will hand it over to Dr. Lyerly.
Thanks very much. Again, that was a very nice introduction and overview, and I also want to acknowledge the participants on the call as well as the cancer support community for sponsoring this webinar. I am going to be starting about the CAR T-cell immunotherapy, and CAR therapy is an acronym for chimeric antigen receptor modified T cells, and it is a innovative form of immunotherapy that actually modifies a patient's own cells. And the modification is accomplished to allow the cells, typically T cells, to not follow the natural direction or the natural recognition of the T cell, but to be modified so that the T cell will now recognize an antigen based on a single-chain antibody linked to a number of molecules that will signal through the T cell. So you have basically a superhero type of cell. It's a killer T cell, but it will now recognize antigens via this modified single-chain antibody. And what's exciting about the role of CAR T-cell immunotherapy is that although it was conceptualized about 20 or 30 years ago, it was built on the basic scientific observations about how a T cell can signal, what are the breaks that prevent T cells from signaling, and finally, what are the barriers to introducing these exciting technologies into therapeutic application for individual people. So right now, CAR T cells are approved. There are two approved therapies. They both target hematologic malignancies because they are antibody-based, targeting CD19, again, a molecule on the surface of hematologic and malignancies, leukemias, and lymphomas. And the patients will have their T cells modified, and the CAR T cell is reinfused, and the CAR T cells tend to react with the circulating tumor cells or the lymphoma cells, and really there have been very dramatic anti-cancer responses, as well as what you might expect, the type of systemic responses due to the release of cytokines from these activated killer T cells. So again, this is exciting to have a cellular-based therapy approved. As you noted on the slide, the patients have a unique product made for them and receive these. These T cells appear to be persistent for essentially the lifetime of the individual. And for many, there's a sense that perhaps the elimination of all CD19 positive cells for the life of the individual may or may not be a problem. It's yet to be studied, but it appears to be one of the challenges of the CAR T cell therapy. Now, as you've heard before, the role of immunotherapy and the breadth of products that exist makes it somewhat confusing, because many people will say, gosh, I'm on an immunotherapy like a CAR T cell or an immune checkpoint inhibitor like the PD-1 or PD-1 inhibitors, some cancer vaccines, and other forms of immunotherapy such as other antibodies or interferons and so forth. So it's useful as when we talk about forms of immunotherapy like CAR T cells to make sure that we use some precision in our descriptions. Again, to review how the specific immunotherapy of CAR T cells works, patients undergo an apheresis. This is very much like donating peripheral blood for bone marrow transplant or having stem cells mobilized from the peripheral blood. The T cells are then sent to a specialized laboratory. They're modified, and then they're expanded in the laboratory and frozen. And this, again, takes some period of time, often weeks. And then the patients will receive treatment. Typically, they're going to receive a form of therapy that will be depleting of many of the lymphocytes in their body. And then during the recovery phase of that lymphodepleting chemotherapy, the CAR T cells are reinfused, and these cells, again, have their sort of effect on the circulating or lymph node associated cells. Now, there have been a couple challenges with the CAR T cells, and as we discussed, the use of the CAR T cells is focused on actually a single chain antibody, and the recognition requires the antigen to be expressed on the tumor surface, and that's very exciting. But one of the things that's fundamentally different about T cells is that T cells have the capacity to recognize genetic changes that are not normally presented on the cell surface. So antigen-presenting cells will present digested peptides on the MHC molecules. And interestingly enough, these digested peptides can come from any compartment of the cell. So a nuclear antigen or a cytoplasmic protein can, in fact, be presented on the cell surface. And the promise of CAR T cells, or the future CAR T cells, will be that they will be, in fact, antigen-specific T cells that would have exquisite specificity to attack almost any antigen within the cell, membrane-bound or even nuclear. And then there would be, of course, a lot of excitement because there are some very unique mutations in cancer cells, and if they could be attacked, we would hope that the adverse events or side effects of CAR T cells would be quite minimal. So there's a lot of excitement in the next generation of CAR T cells, but the fact that they're proven to work and appear to be quite effective is very exciting. As we mentioned, although many of these products have been developed and have been tested in melanoma and in lung cancer and bladder cancer, they have also been tested in some other more common cancers, such as prostate cancer and breast cancer, but the types of responses that we're seeing in lung cancer were not, or melanoma were not seen. And so some have speculated that it's perhaps appropriate to begin to test not only these single immune checkpoints, but perhaps different combinations. And some of the first combinations that have emerged were, as you heard earlier, ipilimumab plus nivolumab for advanced melanoma, or other forms of triggers of the immune system. Some people have shown that some forms of chemotherapy can trigger immune sort of activation within tumors. People have used the oncolytic viruses themselves as a sort of in situ vaccine. The virus would cause cell destruction, and the addition of an immune checkpoint inhibitor would complement that, and we would see an anti-cancer effect. And people have tried a number of things. There are clinical trials being conducted now that combine low-dose radiation therapy, again, as a form of immune modulator in combination with some of the immune checkpoints. So they are exciting times, but I think Dr. Waterhouse had pointed out, oftentimes it's useful to speak to your physician and to go to a reputable center that is conducting high-quality clinical research, really to make sure that you're participating in types of trials that have been thoughtful, that are monitored for safety, and will likely result in, your good care as well as the advancement of knowledge about which of these combinations will work. Now, as you might imagine, people are scratching their heads and trying to understand why is it that the activation of the immune system appears to be so much more active in certain patients and in certain types of tumors compared to others. I will tell you, Dr. Waterhouse mentioned that he's starting to feel old. I feel old all the time, but one of the things I can tell you that being in the field of immunotherapy for many years, there have been many beliefs that have subsequently been disproven. And one of the early beliefs by many cancer doctors is that there were always certain forms of cancer that were immunologically targetable, such as melanoma and kidney cancer, some forms of renal cell carcinoma. And the idea that lung cancer would be the target of immunotherapy would have been laughed at by many 10 years ago. So at the molecular level, people are beginning to explore or try to explain, what are the features of cancers that appear to make them susceptible to immune-based therapies. And some people are wondering maybe that the number of mutations that are present, the mutations will alter the protein sequence. These protein sequences now form neoantigens or antigens that are recognized as foreign by the body. And the fact that more neoantigens are present may suggest that some forms of cancer are more likely to respond. And that data appears to be consistent with some of the observations in which melanoma, lung, bladder is associated with better responses. Again, I would say the jury's not out. You heard that some forms of colon cancer have a very high mutation rate, and in fact, these are the forms of colon cancer that respond. But it's interesting that even with these high mutation rates, not everyone responds all the time, and the question is, why is that? There are other features of tumors, the presence of the protein like PD-L1. It perhaps sends a message that the immune system is starting to work anyway, and the tumor's defense mechanisms have been activated, and that may be an indicator that the patient is more likely to respond. And so PD-L1 expression appears to be an indicator that perhaps the tumors may respond. Again, quite interesting in that not only will the tumor produce PD-L1, but some of the immune cells around the tumor can produce PD-L1, and people are trying to figure out what are the true markers of PD-L1 activation that predict responses. And then there's some other features that might be useful to know, whether smaller tumors or tumors that have a more miliary or disseminated pattern, are those more likely to respond? Certainly in animal laboratory experiments, features of tumors can be manipulated, and those insights are probably going to be tested in human trials to see if, in fact, predictive biomarkers can be identified. Well, one of the questions that has been raised by many individuals, particularly those who have been successfully treated with the immunotherapy, is how long should they stay on it? For many people, the idea that a form of cancer therapy that could trigger a substantial reduction in tumor burden, prolong life, and so forth should be a therapy they should stay on forever. Why would you stop? And the answer is, although it's highly plausible that that's the right answer, it's also potentially possible that there are alternatives. One of the things that have been observed is that unlike chemotherapy, there are many people who have been on a form of immunotherapy that will stop their therapy, and they will have persistent anti-tumor responses. Some people use this term lighting the kindling, meaning that the form of immunotherapy that is activated by an anti-PD-1 antibody triggers the body's own immune system to become a super threshold level and then effectively kill the tumor cells, and that form of killing can actually persist even after the anti-PD-1 antibodies have been stopped. Dr. Waterhouse had some comments earlier about the potential for studies in which long-term administration of anti-PD-1 antibodies was promoted compared to stopping and then treating again as necessary. And there may be some hints that longer therapy might be beneficial. Yet again, it's hard to know. Finally, I would say that although side effects are again a challenge for all patients, and acute grade 3 and 4 side effects certainly are difficult to manage and can lead to cessation or alteration in therapy. Even the fact that you might have a chronic grade 1 or 2 side effect, if it persists for weeks or months, that can be debilitating as well. And so I think one of the things that we know is the mechanism of action of some of these immune checkpoint inhibitors could be in the activation or the persistence of inflammation. And if those are occurring in individuals in which there's no additional benefit to their anti-tumor response, but they are getting persistent adverse events, certainly that would weigh or tip the scales toward, therapy and then cessation. The bottom line right now is that we don't know the right answer, and probably consultation with your physician and open lines of communication with them is sort of the right answer. I will say again that what's exciting about the field is that things are advancing. People are learning more, but we don't have the absolute answer for that question, which is a terrific one. Well, what still needs to be studied in immunotherapy? Again, I don't think there's any question that you've heard the term game changer. Things in my career that I would never expect to see, a new therapy for lung cancer that prolongs life that was developed within, just a few short years. Many people are really profoundly altering their view of immunotherapy just in the last 2 to 3 years. So that's very exciting. But of course, I can't imagine there's any physician that doesn't say, well, why can't all my patients benefit from this? Why are those that don't respond, or in those patients who do respond, why do they have recurrences? And I think that's what, we think we all want to participate in. Why do people not respond if there's an optimal time or an optimal combination in which surgery, chemotherapy, radiation therapy are traditional tools to fight cancer should be staged or sequenced with immunotherapy to optimize that? These are quite interesting questions. Some people have proposed perhaps that rather than starting first with surgery, which is a very common sequence, perhaps in an immunotherapy intervention would be best to train your body to fight your cancer before surgery is utilized and so forth. So I can't tell you today that we want to advocate for these types of strategies, but I would say that they are the type of questions that people are really thinking about. The impact of immunotherapy appears to be so profound that people are really, really thinking about, what is the right sequence and strategy to optimize its use, and how do we make sure that the benefits are as broad and as deep as possible. And of course, how do we make sure that the potential side effects, short-term and long-term, are managed and understood? Well, one question that has been raised is, what kinds of cancer is immunotherapy likely to be approved for in the treatment? Boy, I wish I knew this, because we've heard there are hundreds and hundreds of trials in which forms of immunotherapy as well as combinations are used. Sometimes people will expect answers and they don't occur. As I mentioned earlier, if you asked 100 oncologists 5 years ago if they thought lung cancer would be a target for immunotherapy, my bet would be that the vast majority of them would have said no. They would have been wrong. So I think, again, it calls for the kind of thoughtful clinical investigators like Dr. Waterhouse and others at many centers, many high-quality clinics around the country that are participating in the clinical research, and this may be really the only way to answer these questions in a timely and methodical fashion. Clinical trials remain the best and most efficient way to improve treatments, and that's really because the quality of data and the consistency in the care provided provide opportunities to really learn as much as possible. There are definitely many things that can be done, can be tried, and obviously for any individual patient, their doctors are going to make the best decisions to support them, but the broad knowledge that's possible is going to be through participation in the clinical trials and the clinical research. Why does participation in the trials matter? Well, many people don't participate. In fact, through studies from the National Cancer Institute, many people have felt that less than 5% of eligible patients will actually participate in clinical trials. And again, that's the right of any individual not to participate in clinical research. However, if we don't have people participating, then we won't have active knowledge being gained, and we won't be able to answer these questions. Some of the comments that have been made is that many of the trials involve participants who have certain characteristics. For example, melanoma is not a very common cancer in African American patients, but of course lung cancer is very common in all races, and so the side effects or the response rates for different ethnic groups or sexes could be informed by all people participating and so forth. So these are the kind of things that perhaps as individuals seeking care or knowledge about themselves or their loved ones may not consider, but I do think we wanted to take the time to talk about clinical research and its importance in really advancing the field. And for your own knowledge, other independent sites such as the NCI, the Cancer Support Community, and the American Cancer Society, are providing really registries and opportunities to learn more about clinical research that could be useful for individuals. In addition, I would say this webinar is again, a reflection of the thoughtfulness of the cancer support community in trying to provide information that is not really biased toward any one product or any one company or any one center, but really creating a domain in which interested individuals can get questions answered and feel that there's thoughtful commentary being provided that will be useful for them. As well, there's other information. There are publications, videos, and booklets that are provided. I will tell you that I've known many of the individuals involved in the cancer support community, independent of their positions there, and again, I think they have been a very reliable resource and one that I refer many people to. So again, let me finish by complimenting the cancer support community and their efforts to bring this information in the form of these webinars. Again, I wanted to recognize Dr. Waterhouse in covering years of research and activity in a very brief period of time, and I wanted to thank all of you for your interest, and I would be glad to answer or address any questions.
Awesome. Thank you, Dr. Lyerly. And just to kind of reiterate, for more information about clinical trials, definitely visit www.cancer.gov/clinical trials. We also have a lot of great information, as Dr. Lyerly mentioned, on our Cancer Support Community website at the address listed there. And then we also have several resources about immunotherapy, You can visit our cancersupportcommunity.org/immunotherapy web address for more information on immunotherapy treatments, testimonies from patients and caregivers, videos from healthcare providers, and we have a couple of booklets on immunotherapy treatment. So with that, we'd like to open it up for discussion to the audience. We may have answered some of your questions during the presentation, but if you have any additional questions, please feel free to type them into the Q&A box to the right of your screen, and we are happy to take a second to get some questions and start asking. All right, so I'm going to start with the question. This one will go for Dr. Waterhouse. What is the biggest risk when using immunotherapy?
Well, as I mentioned before, many of the side effects of the immune therapy are reflected by the fact that it is stimulating your immune system, and so inflammatory side effects are perhaps what I would consider the more dangerous side effects. Again, all of them occur in a very small percentage of patients, but they need to be identified. So pneumonitis, for example, which is an inflammatory condition in the lungs, encephalitis, which can cause confusion. These are extremely rare, but boy, if you don't identify them and identify them quickly, the patient can get into trouble. But as I said before, I think that the side effect profile of the immune therapies in a very broad context are actually significantly less than what we see with standard chemotherapy.
Awesome. Dr. Lyerly, do you have anything to add to that?
Well, I think the question is a good one, but I think there are a couple answers just because as we heard, the forms of immunotherapy can be quite broad. So the CAR T-cell therapies, there's a cytokine release syndrome that's quite dramatic. And in fact, there's recommended therapies that will alleviate that by blocking interleukins. That's, again, a very common, anecdote, if you will, for the cytokine release syndrome. Other forms of combination therapies of immune checkpoints, particularly IPI and PD-1 or PD-L1 inhibitor, seem to augment the toxicities, and that's something to think about. The good news is that the response rates, the anti-tumor effects, also seem to be augmented, and so that's exciting to hear about that. And then finally, as Dr. Waterhouse had pointed out earlier, getting treatment for these side effects or toxicities is very, very important. And what's important to realize is that if you have an anti-tumor response, that's terrific. If you have side effects like a colitis or a pneumonitis, you actually can be treated with steroids for your colitis or your pneumonitis, and that doesn't appear to impact the anti-tumor effect. So the idea that an individual may want to tough it out and suffer through their side effects because they don't want their anti-tumor response to be impacted by not being on therapy and so forth, that is really the wrong message. The right message is to get treated, get recognized, get better from your side effects, because the management of those side effects don't appear to have any impact on the beneficial anti-tumor responses. And again, we want you to not suffer from these side effects that can be debilitating and potentially lethal if they're not treated appropriately.
I'd love to build on that comment, because this is something that's actually quite different from chemotherapy. A person gets chemotherapy and their blood counts go very low. We'll hold the chemotherapy, but when we restart it, we may have to change the treatment or change the dose. The immune therapies, it's actually not uncommon to treat them often with steroids and then be able to re-challenge with the exact same dose again to get the same effect and not see the side effect again. It almost defies common sense, and yet we see it all the time. So Dr. Lyerly is extremely correct about getting these symptoms and signs identified early and treated, because they shouldn't be barriers to treatment.
Awesome. Thank you, guys. So this next question I will direct to Dr. Lyerly first. What's the longest remission for someone who has been on CAR T-cell therapy that you're aware of?
Well, again, I wouldn't say I know all of them. There's clearly people that have been alive years that have, had been diagnosed with lethal disease and so forth. On the other hand, there's also, a significant rate of relapse, and there are people that will describe, highly effective anti-tumor responses, but then, recurrence, even with these modified T cells. So it's clearly benefiting people. Why or how anybody would relapse, it's not that clear. There are some studies in which people have lost the antigen, or the CAR T cells may not, maintain their function. It's, again, unknown at this point, but it's exciting that there are, long-term, year-long responders. But again, there is a relapse rate even with the CAR T cells.
Dr. Waterhouse, did you have anything that you wanted to add to that?
I'm racking my brain right now because I know that the longest survivor is a young girl. She was a pediatric patient with acute lymphocytic leukemia. And it's definitely measured in years, quite a number of years, but I don't recall the exact number.
Awesome. All right, so Dr. Waterhouse, I'll direct this question to you. It was asked, can immunotherapy cure cancer, or does it just extend someone's life if they're dealing with a cancer diagnosis?
Well, we don't know the answer to that yet. These drugs are still in their infancy. The term cure is not necessarily a medical term. It's more of a layman's term, because I tend to think of cancer that even if you are a survivor, you're living with that cancer. Even if we can't find that cancer, it's completely disappeared by x-rays, by blood tests, by physical exam. You're still surviving, and you're still influenced by the experience that you went through and the trauma that you went through. So I tend to think of survival and not necessarily in terms of cure. That said, we clearly have cohorts of patients, groups of patients, who have been treated and are now out several years with diseases that historically we never saw complete and durable responses. I think of a gentleman in my own clinic who's now a volunteer in our clinic. He was one of the original nivolumab patients. He had failed chemotherapy. He had cancer that had spread to his liver and to his brain. He elected to go on a clinical trial, one of the original trials, and he just celebrated 5 years of cancer-free survival. And he has no evidence of disease right now, and he's thriving. And if someone asked about duration of therapy, he still gets his nivolumab every other week. So on those days, he's a patient in the clinic. On other days, he's a volunteer. So we don't know the answer to that yet. The one thing we know is that there are not enough of these people, and that's why the research is so darn important.
So, Dr. Lyerly, did you have anything to add to that?
No, I think that was well said. I think, it's all very exciting. We all have individuals like that that we know and admire, and, we hope there are more.
All right, so I'll direct this next question to Dr. Waterhouse again. How long do inflammatory side effects last once therapy has been discontinued? So, for example, inflammatory arthritis.
Sure. Well, that's one of the things that we're seeing with these side effects is they are not as predictable as the side effects that we see with chemotherapy. Often with a chemotherapy drug, you can tell a patient, my goodness, your white count is going to go low and it's going to hit its lowest point at day 10, and it's going to recover somewhere around day 14 to 18, or something of that nature. We could tell someone they'll lose their hair 2.5 weeks into treatment. With the immune therapies, we notice that the range by which a side effect can occur is quite large. It can occur literally within days, but it's not uncommon to see some side effect emerge even months out from the treatment. And in the same vein, how fast they recover is partly a function of how early it's identified. Obviously, if you identify a side effect early in its nature, what we talked about earlier, grade 1 and grade 2, it is much more likely that they'll get over that side effect with treatment much quicker than if you identify the side effect later as a more serious side effect. In most of the clinical trials that launched all of these drugs, oftentimes when these side effects, if it was an inflammatory side effect, it was often treated with higher doses of steroids. And in those settings, we would have up to 12 weeks to treat this and get them back off of the steroids and reinitiate treatment. So the treatment may have gone on for weeks in those patient populations. This is different than the side effects such as the deficiencies. A patient with hypothyroidism, you can get them on thyroid medicine and initiate the treatment rather quickly. So it is dependent on what the side effect is, the grade or the severity of the side effect, and how quickly the treatment was initiated. So it's a little different for each individual and much more variable with the immune therapies than, say, with chemotherapy.
Dr. Lyerly, did you have anything that you wanted to add to that?
No, I think as you heard, some of the responses we are giving are, we need to know a little bit more. I will say that there's a big interest in a long-term type of surveillance for people who are on chemotherapy or immunotherapy, and the reason being that as we remove these immune checkpoints and we trigger an anti-tumor response, we do want to know about the long-term adverse events that may be indolent at this point. And as you heard, some of the side effects do take a longer period of time. Some of the side effects or adverse events are present and then they disappear. They don't recur. But of course, we want to make sure that there aren't chronic, uncommon side effects that will occur, particularly as these drugs are now being utilized outside of the clinical trials where the very close monitoring of side effects may not occur. We want to have long-term lung cancer survivors, and we want to make sure that they don't have the kind of adverse events like type 1 diabetes or any neurological disorders that potentially or theoretically are associated with anti-self immunity. We don't have any evidence of that at this point, but I think people are expressing some caution in making sure that we're thoughtfully addressing the potential mechanistic activities that are associated with anti-tumor immunity.
So this is kind of a follow-up question to that. If you do develop an inflammatory side effect like colitis, does that mean that you have to stop all of your immunotherapy treatments? And I can direct that to Dr. Lyerly first.
Well, I think the thing about the immunotherapies, particularly the antibodies are going to persist in your body for weeks. And obviously, if you have a colitis that's dehydrating, you're having a lot of abdominal pain, you're going to get active therapy for that. And as you heard earlier, they reinstating or getting a second cycle of your immunotherapy, particularly the PD-1 inhibitors, that may or may not be impacted. I think with the anti-CTLA-4 blockade, this is the ipilimumab, in which the specific synapse between the antigen-presenting cells and T cells is blocked, so you have persistent, ongoing expansion of T cells. That appears to be a type of immunotherapy where you may want to stop or take a holiday from that. But I think the PD-1, PD-L1 type of therapies appear to be more forgiving. So that would be my perspective. You clearly want to get your colitis or your pneumonitis managed aggressively. But again, it's kind of different because you're not going to go and get your antibodies removed out of your plasma. It's just really a question of when you get your next treatment and what the dose would be of that.
Did you have anything that you wanted to add to that, Dr. Waterhouse?
Sure. In general, if it is a severe side effect, a grade 3 or grade 4, you absolutely want to stop the drug. And in fact, I would say, unless it's a very mild form of the side effect, almost always you're going to hold the drug. But I would not fear holding it. As was mentioned, just because you're not getting the drug doesn't mean you've suddenly turned off your immune system. It's still turned on. That's part of the problem. And so you treat the side effect, and when you effectively treat the side effect, you can then get back off of the steroids and get back on your treatment, often right at the same dose again. The colitis, specifically, it was mentioned with ipilimumab. When ipilimumab was first launched, it was frankly at a significantly higher dose. And in those patients, there were even lethal cases of colitis. Now, as we understand the dosing a little bit better and we recognize the need for early intervention better, I don't think it's quite as toxic as it was when we first started. And colitis, now I think most docs are pretty savvy into recognizing it and intervening early. And for many of these side effects, your doctors all have algorithms that they can follow that basically mimic what was done inside the clinical trials to manage these, or were informed by later trials as to exactly how to treat them. So again, don't let these become barriers to treatment.
Perfect. So our next question is, we touched a little bit on how a lot of patients have to go through chemotherapy or other therapies and essentially have those fail before they can try an immunotherapy treatment. So the question was brought up, how does an immunotherapy drug become a first-line treatment option for cancer patients? I'll direct that to Dr. Waterhouse, and then Dr. Lyerly, you can jump in afterwards.
Sure. Many of the ways that the clinical trials are developed for the immune therapies hail back to an era of chemotherapy. And whether or not we're using the right approach or not remains to be seen. But if you think about how most drugs came about, often they were tried in patients with advanced disease who had failed other conventional treatments and really had very few choices in front of them. So most drugs, including the immune therapies, first were launched in patients who had failed known and proven effective treatments. It's hard to offer a treatment that you don't know how it's going to work to somebody who has a potential offering of a treatment that we know does have the potential to work. Once the drug is used in that setting, if it's found to be effective, then oftentimes it'll move up into earlier stages. So you would go from an advanced stage, say in the second or third line of treatment when the conventional chemotherapies had failed. You now say, hey, look, this drug is working. It looks like it's working as good, if not better, than a standard chemotherapy. I'm going to try and see how it does earlier in the treatment. So it moves up into maybe the first treatment after failure chemo. After that, it moves up into, hey, maybe it's as good as chemo. I'm going to compare it to chemotherapy in the front line. And so it really is a well-orchestrated dance of these trials that are pre-planned for a pathway to getting these drugs determine whether they're safe, whether they're effective, and whether they're as good, if not better, than conventional treatment. So usually the drug has to be proven first in a setting where a patient may not have other choices. I think that you're seeing these drugs moving up very quickly at a pace that's much faster than what we ever saw with standard chemotherapies. The development is lightning fast. I mean, as you guys know, I had to actually go on the FDA web pages to make sure we had all the indications correct today, because they literally are changing by the week.
Dr. Lyerly, did you want to add anything to that?
No, I think that was well said. The use of a medicine, really requires evidence to show it's beneficial, particularly over medicines that have a proven benefit to patients, and that's usually the role of the clinical research to make that. There are many things that look very promising that turn out not to be beneficial, and so certainly just because we think it should work, we think that would be kind of a leap of faith just to assume that it does and not participate in the appropriate therapy for your or your loved one's disease.
Perfect. So I'll direct this next question to Dr. Lyerly. Is it true that having good bacteria immunotherapy patients limit the antibiotics that they take that could reduce the amount of good bacteria in their gut? Should immunotherapy patients look at taking probiotics? What are your thoughts?
Well, the understanding of the microbiome and its impact on all of our health states, in particular the role of bacteria and their role in setting our immune levels and thresholds, is quite interesting. And there are some early studies that have proven to be quite provocative, in that they suggest that we know that there are bacteria that are predicting responses and so forth. I would say that in these early observations, that if they do what we call generate a hypothesis, or they create an idea that's quite exciting. But it's not until people do the clinical research, the research that says, oh, here is the right form of bacteria. The use of taking probiotics is truly going to be beneficial. I would tend not to jump the gun, because I can tell you, and I don't want to bore you, with many instances where people thought they knew the answer and it turned out they were completely wrong, and people would have been much better off doing something very different than what people had thought based on early studies. So this is the scientific literature is definitely based on good quality work in which hypotheses are generated, things we couldn't even imagine would have an impact, and it creates the opportunity to say, well, gosh, this may have an impact. Let's study this and develop a set of reliable data that will inform how to manage ourselves and so forth. Clearly, eating healthy and reducing the many things that are stressful in our lives by maintaining our weight and our exercise and our sleep, there's no question all those things benefit us. And I think the role of the microbiome, it's very exciting, may potentially be something that we can act on. But I think at this point, it's, again, for those who are, with disease or managing care, I would say it's a little bit early to provide a definitive answer.
Dr. Waterhouse, did you have anything that you wanted to add on to that?
No, I think, again, very well explained. We don't know. As I said, this is why we encourage participation in clinical trials. It was mentioned earlier that some of the docs were hesitant to get involved with immunotherapy, believing it wasn't going to work. I'll be perfectly honest. I was one of those people. When we were offered the very first clinical trials available in this, I actually turned them down, saying my docs wouldn't support it. It was only later that somebody convinced me, listen, you'll regret that decision. Get involved early. We did, and I'm changed. So now when someone comes and tells me that managing the bacterial content in my gut may change how my treatment works, I am a lot more open to that idea, but I would like to see it proven in a scientific fashion as opposed to an anecdotal description or somebody's, Facebook page. I would love to see it done in the context of clinical trials. I do believe that is the best way to develop the science.
And we have another question. I'll direct this to you, Dr. Waterhouse. What happens if a patient is on an immunotherapy treatment and they stop responding or progression occurs? Are there options to try different immunotherapy treatments? Do they go back to chemo? What have you seen in your practice?
Well, unfortunately, there's a large number of patients who may respond but don't respond forever, and they will develop progression of their disease. What to do next often is a question of that's open to the scientific community. We don't know. More often than not, they'll go on chemotherapy again. Whether or not they can be re-challenged with immunotherapy remains to be determined. There have been anecdotal stories and case reports where a patient who had failed an immunotherapy went on to other therapies and then went back to immunotherapy and it was able to work again. The theory behind that is that during the time that their disease was progression, they were developing other mutations, and some of these mutations could be recognized by the immune system. There are trials out there now targeting people who have failed immunotherapy using combination immunotherapies or other studies. So it's an unanswered question. There are definitely clinical trials out there trying to address that. Often they're disease-specific, such as a lung cancer trial or a colon cancer trial. But I would encourage someone who's faced with that situation to look for a trial first and to at least ask that question of their doctor.
And Dr. Lyerly, did you want to add anything to that as well?
No, I think it was well stated.
So I'll actually direct this next question to you, Dr. Lyerly. Many clinical trials of checkpoint inhibitor immunotherapy drugs exclude people with autoimmune disorders. Is it true that if you have an autoimmune disorder, you can't get immunotherapy?
Well, I think the jury is out. The mechanism, as we've heard, of effective anti-cancer responses may be to these mutations within the tumor itself, and the type of autoimmune disease often manifested by antibody type of responses rather than T-cell responses may enable people to, be on forms of immunotherapy. Again, I think people are going to cautiously look toward including more and more people in those types of studies, but I think people are going to be very cautious about that. So I think one thing we need to do is study that a bit more. Again, on the flip side, we are aware of these anecdotal stories of people recovering from their cancer and then developing autoimmune disease. But people develop autoimmune disease without ever getting cancer or without ever being on immune checkpoint inhibitors. We just don't know if there's a causal relationship with that, and whether or not in the long run we'll figure out how to manage it. So at this point, I think there's a lot of caution, but I think there's going to be explorations in how to manage patients with autoimmune disease. And as you can imagine, the breadth of autoimmune disease and the toxicities and the magnitude of that autoimmune disease can be quite broad, and so there's probably going to be some explorations and perhaps those who have more milder manifestations.
Dr. Waterhouse, did you want to add anything to that?
No, I think that the original fear was that by turning on or jazzing up the immune system, that you might make their pre-existing problem worse, was the concern. And so you're absolutely right, these patients were excluded to a large extent from the clinical trials. As we get more comfortable with the use of these drugs, we're more comfortable with the management of the side effects and things, we're seeing the eligibility criteria, in other words, the cookbook by which people get involved in clinical trials, broadening a little bit, and there are even some trials directed specifically at these populations. We now don't see as much exclusion for thyroid disease, for example. Diabetes is not an exclusion criteria as it was early on. So I think as we learn more, I think you'll see that the indications broaden and the entry criteria into trials loosen up a little bit, but we have to tread softly. Just as with chemotherapy, it has never been our goal to make the treatment worse than the disease.
All right. We're getting towards the end of the webinar here. Looking to see if we have any final questions. It doesn't look like we do, so I will go ahead and start wrapping things up. We'd like to thank our wonderful panelists, Dr. Waterhouse and Dr. Lyerly, for contributing their time and sharing this important information with us. Thank you very, very much. CSC would also like to thank our program supporter, Merck. Please take a moment to complete our webinar evaluation survey, which you will be automatically redirected to. We greatly appreciate any feedback that you may have, and your feedback helps us to develop future webinars and make them as great as we can. So thank you to everyone for your participation. Thanks again to our panelists, and please enjoy the rest of your day. Thank you.
Thank you.